Wonderful, thank you. Good afternoon. I would like to talk about two different major aspects of lymphoma survivorship. The first is chronic health conditions, including cardiovascular disease, secondary malignancies, loss of immunity, and then psychosocial needs. The other part is patient engagement. Patients oftentimes ask me, well, now that I've had lymphoma, what can I do to prevent this from coming back or to prevent long-term health effects? And then end with just a few words on survivorship care models. So this was set up very nicely this morning when you heard about Hodgkin lymphoma as the kind of disease where we have late effects related to prior mantle radiation, MOP chemotherapy, et cetera. So why do we talk about this? This really didn't become part of oncology science up until about 10, 15 years ago, because it didn't have to be. We didn't have that many survivors. So back in the 1970s is when the United States started keeping track of this. And there were only 3 million cancer survivors then. Now we are up to 15.5 million. This is going to be greater than 20 million within the next 6 years. And you can see in the graph that hematological malignancies really do occupy a big part of that pie graph in patients living out the rest of their lives. And when we're talking about lymphoma specifically, lymphoma survivors, lymphoma, as you know, is such a heterogeneous disease. There's 60 different subtypes. They have very different clinical behaviors. They affect different ages of individuals, and there's different expectations of cure. So when we're thinking about what are the issues that patients will face after they've had treatment for lymphoma, we really need to start with what's the subtype that we're dealing with, what kind of treatment did they have, what's their prognosis, do we expect that they're cured? Do we expect that their disease will come back? To really come up with a good plan for these patients. I'll start by talking about cardiovascular disease, as that's one of the major issues that face lymphoma survivors. And cardiovascular disease can come about from either radiation or chemotherapy. Of course, some of our novel agents also have cardiovascular toxicities, but I'm going to touch on really the more traditional issues with radiation and chemo. So radiation causes fibrosis, and this can be anywhere in the heart. It can be in the myocardium, it can be in the valves, the conduction system, and certainly the coronary arteries. It depends on where that radiation hit. So if a patient was treated with mantle radiation at high doses 20 years ago, before there was very good shielding of the heart, this could be quite an issue for a patient. Chemotherapy also can lead to late cardiovascular effects, and anthracyclines are the major class of drug that is associated with this long-term effect, leading to myocyte loss and damage and eventual heart failure. Who is at risk? In a prospectively collected study of patients who were survivors of lymphoma, we collected new incidents of cardiovascular disease. So in patients who did not have heart disease when they got lymphoma, how many are going to go on and develop heart disease? 1% per year. Now, some of that may of course be related to age, as generally this is an aging or an older population. But another thing to note is that these may be early events. Sometimes we'll see that, but oftentimes these events are later, 10, 20, even 30 years after treatment, which leads to some of the challenges of how do we monitor patients, and we'll talk more about that in upcoming slides. We know that, of course, radiation and anthracycline are the biggest risk factors, but there are also traditional cardiovascular risk factors that also will increase the risk, including smoking, lack of exercise, a strong family history, hypertension, hypercholesterolemia, diabetes, etc., are traditional cardiac risk factors. So if we have a patient who has been treated for lymphoma, how do we counsel them about their risk of developing potential heart disease down the road? First thing, I tell all my patients, you need to have a good primary care physician who can monitor your heart health. That means checking your blood pressure, checking your lipids every 3 to 5 years. I am not good at doing that anymore. I'm certainly not good at managing it. And then also checking the fasting glucose, particularly for those who received para-aortic radiation, as much of that radiation may have hit the pancreas, and there is a higher risk of developing type 2 diabetes. Treat those cardiovascular risk factors aggressively, and then lifestyle modifications with exercise, stopping smoking, etc. Besides those things, we can also do surveillance for development of new cardiac disease, and we now recommend for those who received greater than 240 milligrams per meter squared of anthracycline, so that's basically anyone who got 6 cycles of R-CHOP or ABVD, that we do an echocardiogram early. It used to be a little bit later when events may happen 10, 20 years down the road, but now we have data that subclinical changes can be seen within the first 12 months of completing therapy that are predictive for developing late cardiovascular effects. And that's the window of opportunity where we can start medications such as ACE inhibitors and beta blockers that lead to cardiac remodeling and hopefully prevent clinical heart failure down the road. We do not just ejection fraction, but also strain imaging on the echocardiogram, which is a sensitive marker of anthracycline-induced cardiotoxicity. For those who received radiation, meaning greater than 30 gray to the mediastinum, they are at additional risk not just of congestive heart failure, but also coronary artery disease. And therefore, doing an echocardiogram with stress is important, starting 5 to 10 years after therapy. Secondary malignancies is also a very important subject. It can be a devastating complication. Both chemotherapy and radiation therapy, unfortunately, do have the risk of developing or increasing the risk of developing a secondary malignancy, as they are carcinogenic in and of themselves. We know that 10% of all new cancer patients have had a previous diagnosis of cancer. Now, not all of those are late sequelae of treatment. Certainly some of these are genetic risk factors, lifestyle, and environmental exposures. Let's talk about what types of secondary cancers we see in lymphoma survivors. The number one is breast cancer in young women, young girls and women who are treated with mediastinal radiation, particularly between the ages of 15 and 35. In fact, their risk of developing breast cancer is as high as if they had a BRCA mutation, and therefore they need to be aggressively screened. They require annual mammography and breast MRI starting at age 40, which I'll get to in the next slide. Also, thyroid cancer, lung cancer, secondary malignancies. I currently have several patients in my practice with a history of Hodgkin lymphoma, mantle radiation, and now 20, 30 years later, they have a lung cancer as a result. If those who smoke following radiation therapy to the chest, of course, that's an exponentially increased risk. Radiation, wherever the radiation was, will increase that risk of secondary malignancies. So those who received abdominal radiation, they may have an increased risk of GI malignancies. And then AML and MDS is mostly related to the alkylating agents that we do with chemotherapy, but radiation also, of course, increases that risk. And then those with Hodgkin lymphoma have about a 5% lifetime risk of developing a non-Hodgkin lymphoma. That's probably not related to the treatment, but more their genetic makeup. So what do we recommend? For those who received radiation, they need an annual skin exam in the radiated field. I mentioned annual mammography and MRI for young women who received breast radiation starting 8 years after treatment or at age 40, whichever comes first. For those who receive pelvic, abdominal, or spinal radiation, they're at risk of early colon cancer, and so colonoscopy needs to be started 15 years after therapy or at age 35, whichever comes first. Tobacco cessation, of course, and then this risk of secondary malignancies never plateaus. The risk keeps increasing as patients get older, and therefore lifelong surveillance is necessary. All right, let's talk about loss of immunity, which seems quite timely in the era of coronavirus. Certainly, our patients who have been treated with chemotherapy have a loss of immunity. If they've had a splenectomy or a bone marrow transplant, this is even more. These patients should not receive live vaccines. They should receive their influenza vaccine annually, but no flu mist because that is the live vaccine. They need the injectable. Shingrix is the new zoster inactivated vaccine that's very effective. Their tetanus shot, HPV, and then pneumococcal vaccine. These are important even in younger patients if they don't meet the age criteria. They still meet the criteria for these vaccines. Unfortunately, we have some recent data published last year showing the effectiveness of influenza vaccine in patients with malignancy. The two lines on the left are those with solid tumors. Far left, no chemotherapy. Next one over is those on chemotherapy, so about a 20-ish% effectiveness. When we move over to the lines farther to the right, those are our patients with hematological malignancies. You can see those who have a heme malignancy not on chemotherapy, the effectiveness is only about 10%. For those with a heme malignancy on chemotherapy, that effectiveness is basically zero. That being said, it is still important for patients to receive the influenza vaccine because even if they still catch influenza, it may be not as severe and may prevent complications including pneumonias and ICU stays. This also raises the issue that our patients are not well protected no matter what they do, and so their families and close contacts really need to be immunized to protect their the patient who is affected by malignancy. Those who receive splenectomy or splenic radiation require, of course, the vaccines prior to that event, but recall that they also need boosters every 5 years. I oftentimes see that patients are not receiving those ongoing boosters. And then, of course, if they've had a stem cell transplant, there's a much more complicated vaccine schedule that I won't go through in detail. All right, psychosocial issues. We talk about quality of life and measure quality of life in patients, but I think it's important to take a moment and think about what is quality of life. It's a pretty broad term. It's multidimensional. It takes into consideration the physical and functional aspects of patients, and that's most of what drives quality of life in our patients with cancer, but also social and emotional effects as well. And obviously, those who are diagnosed or affected by cancer will have a change, generally a negative change in their quality of life. This study looked at the incidence of depression and anxiety in cancer survivors, and what they found is that depression was higher than the general population initially after diagnosis for those first 2 years. But then over time, it reached the same level as the general population. So this is not a long-term effect. However, anxiety was a little bit different. Those levels are higher than the general population after 2 years and do not go down over time. That generally is more health-related anxiety as opposed to a generalized anxiety disorder. This was a study out of Norway showing the incidence of anxiety in non-Hodgkin lymphoma survivors of 14% versus their general population of only 3%. This one is very interesting. This measured anxiety in the spouses of those with lymphoma and found in this meta-analysis that almost every study showed an increase compared to the general population of spouses with anxiety, not just patients. And I think most of us who treat patients in clinic know this to be true. But it's not all bad. There is a silver lining for some patients, and this is called positive sequelae of having a life-threatening disease. Sometimes people will get post-traumatic stress disorder. This is called post-traumatic growth. And in this study of patients with heme malignancies, those who compared their life before and after cancer actually reported better outcomes with religion, relationships, outlook on life, and friendships after lymphoma than before. And in fact, in a study that we presented a couple years ago, we looked at quality of life in lymphoma survivors 3 years after diagnosis. Compared to the general population, the quality of life was actually higher. All right, so let's go to patient engagement. That question of, doctor, what can I do now to remain healthy so this lymphoma never comes back, or so that I don't develop late effects of the chemotherapy and radiation? So a couple of things. I want to focus on exercise. There's actually very good data showing benefits of exercise in cancer survivors and lymphoma survivors specifically. It improves fatigue, decreases depression, anxiety, improves insomnia, physical function, immune system, decreases the risk of developing heart disease, and we now have data that it decreases the risk of lymphoma returning, and I'll show you that data. So this is a prospective data collected from that same cohort where patients reported their exercise level both at the time of diagnosis, at baseline, and then 3 years later. And what we found in those survivors 3 years out, those who report higher levels of physical activity at that time have a decreased risk of the lymphoma relapsing. And this is lymphoma-specific survival, statistically different based on physical activity levels. This isn't just those who are athletes at the time of diagnosis. We asked about change in those who increase their physical activity after their diagnosis of lymphoma, also had improved outcomes. So I think there's very strong data for the role of exercise in our lymphoma survivors. In addition, in Hodgkin lymphoma survivors who received mantle radiation, we know they have an increased risk of cardiovascular disease. And this study from the childhood cohort showed that those who were more active had a decreased risk of developing any cardiovascular disease related to the radiation, including valvular disease, coronary artery disease, congestive heart failure. So how to get started? This is one of my patients. She doesn't look like a real active lady who's going to the gym all the time, but small starts can lead to great results. Here's the recommendations for cancer survivors. Physical activity, anything. This can be walking as a great place to start. 3 to 5 days a week. Should be fairly light to somewhat hard. Start off slow, get better, gradually work up to 30 to 60 minutes, 3 to 5 days a week. In addition, add in strength training 2 to 3 days a week. Start with light, build up, 10 to 15 reps. So this doesn't have to be training for a marathon. This can be walking and light strength training. What about diet? This is a common question that we get. There's no data that I am aware of that any change in diet will decrease the risk of lymphoma relapse. We do have data on prevention, however. This is from the Iowa Women's Health Study, which showed that in women who ate more total fruits and vegetables, more cruciferous vegetables, more yellow and orange, more broccoli, and then interestingly, apple cider and juice had a lower risk of eventually developing lymphoma. So I think it makes good sense to tell patients that broccoli and cruciferous vegetables are very good and may have an impact on their lymphoma. This study showed that the Mediterranean diet decreases the overall risk of cardiovascular disease and death in the general population. And therefore, this is one that I think there's good scientific data to recommend the Mediterranean diet, whole foods, plant-based foods, avoid added sugar, read your food labels, and drink plenty of water. So this is the common sense information that I give to my patients.
2 minutes, please.
Thank you. I will end with how do we really take care of survivors and talk about care models. This is the way that we do this at Mayo Clinic. So initially, we had patients coming in for diagnosis and then a treatment plan. And at that point, a nurse would meet with them and go through chemotherapy teaching. But then we know that this real issue of survivorship and what do I do next and of anxiety happens as patients finish therapy and transition into surveillance and survivorship. So we added a second visit here, survivorship clinic visit, where we do an assessment and then hand out what's called called a survivorship care plan, individualized to the patient based on what type of lymphoma they had and what we recommend for surveillance, whether that's the echocardiogram, the diet, the exercise, et cetera. Patients get a copy, their primary care physician get a copy, and they can access it within their medical record. We screen for psychosocial issues and refer to psychology, social work, et cetera, as needed. So in summary, lymphoma patients do have unmet needs at the end of treatment. We mentioned the late effects, the chronic health issues, in particular cardiovascular disease and secondary malignancies. There are psychosocial needs. Patients require surveillance. And patient engagement is important. Physical activity and diet can make a difference for these patients, and coordinated models of care are necessary and challenging in every health system. Thank you.
Thanks, Dr. Thompson. So we have time for 2 questions. Yep.
Thank you, Dr. Thompson. So for our transplant patients, we do vaccinate all of them, but I'm not aware in the practice, in the real practice, if somebody vaccinates their lymphoma patient. Does anybody do it?
Flu vaccine for sure, like influenza vaccine.
Flu vaccine, yeah, flu vaccine for everybody,
we
including non-lymphoma. But the other vaccines you mentioned, I'm not aware of anybody who does it.
Actually, in our center, Dr. Imam Al-Jishi from infectious disease is collecting the data of giving pneumococcal vaccine of the 13 and 23. Mm-hmm. I saw in your slide one of them mentioned 26 and another one mentioned 23. I don't know if there is any difference between them. But
So
anyway,
it's the 13 and the 23. There might have been a typo there, sorry.
So anyway, we are collecting the data of response after those vaccines.
Mm-hmm.
Sorry, thank you. A common survivorship problem patients face in the society and all other societies is fertility issues. So do you address fertility issues in someone who becomes infertile as a result of radiotherapy or chemotherapy can have a very poor quality of life and other issues? And many of these patients, when they get diagnosed with cancer or aggressive lymphoma, maybe they will not have any time to do anything about this before they start therapy, and they end up having no choice but becoming infertile. Mm-hmm. Any suggestions in this setting?
Yeah, thank you for that question. There are so many late effects that I didn't obviously have time to talk about all of them, but infertility in our young patients is a devastating complication of therapy. In a qualitative study that I did many years ago, a theme that came up around infertility from young patients who had developed that complication was the devastation that it occurred, but also the devastation that it was never brought up at the time of diagnosis as a possible complication. So I learned personally a lot of lessons from that there may be times, acute leukemia, a very aggressive lymphoma, where you do not have time or resources, et cetera, to do reproductive endocrinology and all of that. But at least having the conversation with patients so that they are aware that it may be a risk down the road, I think goes a long way for patients. Otherwise, if treatment can be delayed, then having that discussion and having a good network of providers that you pair with in reproductive endocrinology for patients is key. Obviously, it's easier for men as opposed to our female patients for preservation of fertility, but nonetheless, having all the options and getting them the education is imperative. Thank you for bringing that up.